Welcome to the podcast to preserve, protect, and defend the soul of America. I'm Alex.
And I'm Sam.
The topic we shall discuss in today's show is the American healthcare system, unaffordability, medical bankruptcy, and why the U.S. stands alone. And, our mission for this deep dive is to really unpack an incredibly dense, profound stack of source material to figure out exactly how the U.S. healthcare system became a global outlier. We really want to understand why it costs so much and why, despite decades of debate, it seems so impossibly hard to fix.
Exactly. And, the source material we're working with today goes incredibly deep into the historical and empirical facts. So our goal here is strictly analytical.
Yeah.
We are going to examine the data impartially without taking any political sides at all. We are just here to follow the architecture of a system that affects every single person listening to this right now.
Okay, let's unpack this by starting exactly where the text does, which is with a deeply unsettling parallel. I want you, the listener, to just imagine facing the absolute most terrifying medical news of your life. You get a diagnosis that just makes the room spin. And then, as you are sitting there trying to process your own mortality, you slowly realize that the financial bill for your treatment might actually be more dangerous to your family's long-term survival than the disease itself.
That's a terrifying thought.
Yeah.
And the research introduces us to this reality through two composite portraits, which are based on extensive demographic data and published accounts. First, we have Laura Bogar. She's living in Columbus, Ohio, the year is 2019, and she is diagnosed with ovarian cancer.
Right.
Her treatment is standard but highly aggressive. We are talking about major surgery, rounds of chemotherapy, extensive follow-up imaging, and just a mountain of prescription medications. The bills generated by this care total just over $200,000.
That means she has insurance, right? Because that is the part of the American system that always requires a second look. People just assume the uninsured are the ones going bankrupt.
Right, but she is fully insured. Her employer-sponsored insurer pays its negotiated share. However, because of high deductibles, co-pays, co-insurance, and a few inevitable out-of-network charges.
Oh, right, from specialists who just happen to operate at an in-network hospital.
Exactly. Because of all that, she is left with an out-of-pocket balance of approximately $32,000.
And like the vast majority of Americans, she doesn't just have 32 grand sitting idle in a savings account.
She doesn't. So she maxes out her credit cards, she drains what little retirement savings she has, but she simply cannot keep up with the cascading bills. Ultimately, she is forced into personal bankruptcy. Her credit is destroyed, her financial future is completely reset to zero, all because she happened to get sick.
God. Now, I want you to hold that image of Laura in Ohio, and let's cross the Atlantic to see the second half of this parallel.
Right. So that exact same year, 2019, we meet Ingrid Magnusson in Stockholm, Sweden. She receives the exact same diagnosis, ovarian cancer. She receives similarly aggressive, similarly successful, and if we are looking at the raw resources and time required by the medical system, similarly expensive treatment.
But the financial outcome for the patient is from a totally different universe, isn't it?
Completely different. Ingrid pays a series of small co-pays for her clinic visits and prescriptions. They total about 1,100 Swedish krona, which translates to roughly $100 US.
Wow, $100.
Yeah, and at that point, she hits Sweden's high-cost protection threshold. After that threshold is met, the state covers all her health care costs entirely for the next 12 months. She pays nothing else. She keeps her home. She keeps her savings. She doesn't go bankrupt. Her financial life is totally insulated from the disease.
It is the absolute definition of a paradox, The United States spends more money on medicine than any nation in human history. We have top-tier doctors, the most technologically sophisticated hospital systems on the planet, and yet we routinely destroy the financial lives of the people being treated.
Yeah.
It's just wild. The text makes it very clear that among developed nations, the U.S. stands completely alone in permitting its citizens to be routinely bankrupted by medical bills.
Or, as the source material so aptly subtitles its analysis, a nation sick with its own cure. We don't stand apart by accident. We don't stand apart because we lack the immense wealth required to cover our population or because our policymakers are entirely unaware of how other countries manage their health sectors.
Right.
We stand apart by choice. Or, well, more accurately, through the accumulated consequences of highly specific political and economic choices made over more than a century.
Which means we need to do some digging. The research refers to this as the archaeology of American healthcare. And honestly, reading through this, my biggest takeaway is that this system was never actually designed. Not in the way a legislative body sits down, draws up a cohesive blueprint for a welfare state, and says, hey, here is our foundation, let's build.
The text actually uses a brilliant word for this. It calls it a palimpsest.
A palimpsest.
Yeah, it's a very old manuscript where the original writing has been erased to make room for later writing, but traces of the original remain. The American healthcare system is basically layers of policy written over older policy, institutions grafted onto other institutions. Each new layer tries to fix the failures of the last one without ever being allowed to tear down the old structure entirely.
It's kind of like building a massive mansion in the dark. You just blindly add rooms over decades. You build staircases that go nowhere, you install conflicting plumbing systems, you patch a roof over a courtyard that was never meant to be indoors, and then a century later, you're standing in the kitchen wondering why the water pressure is terrible and the lights keep flickering.
That is a perfect analogy. And if we connect this to the bigger picture to understand the foundation of that dark mansion, we really have to go back to the late 19th century. Before industrialization, healthcare in the U.S. was essentially a cottage industry. Physicians were independent tradespeople.
They weren't exactly the highly compensated elite professionals we think of today, right?
Not at all. They charged fees directly to the patient, sometimes bartering chickens or firewood for their services, and sometimes they just worked for free if a patient couldn't pay.
And hospitals were totally different entities back then, too. They weren't these gleaming towers of technology.
Far from it. Hospitals were mostly charitable institutions run by religious orders or municipalities. They functioned essentially as almshouses for the indigent or the dying. If you were wealthy and got sick, you stayed far away from a hospital.
Because it was basically a death sentence to go to one?
Exactly. The doctor came to your house. There was absolutely no concept of medical insurance back then because there was very little effective medical technology that was expensive enough to require pooling financial risk.
But then the science catches up, and the text points to the year 1910 as this massive turning point.
Yes, 1910 marks the publication of the Flexner Report. This was an evaluation of medical schools in the U.S. and Canada, and it was a total bombshell. It found that many medical schools were basically diploma mills teaching pseudoscience.
Yikes.
Yeah, so the report imposed strict, German-style scientific standards on medical education. It led to the closure of substandard medical schools and completely transformed the physician from a local tradesperson into a highly credentialed, scientifically rigorous professional.
Which, on the surface, is fantastic, I mean. We want doctors who actually understand anatomy and germ theory.
It absolutely improved the quality of care. But, structurally, we have to look at the economic side effect here. By strictly limiting the supply of credentialed doctors, because suddenly it was very hard and expensive to become one, the Flexner Report consolidated enormous power into the hands of physicians and their professional associations, most notably the American Medical Association, or the AMA.
And if we connect this to the bigger picture, the source material argues that this newly empowered AMA would become the most formidable institutional obstacle to any form of universal or publicly administered healthcare for the next 100 years.
That is exactly what happened. We see the immediate effects of this unified lobbying bloc during the Progressive Era from roughly 1905 to 1920. Reformers in the U.S. were looking across the ocean at Germany under Chancellor Bismarck or Britain under David Lloyd George. Those countries were setting up early forms of social insurance.
Because industrialization was just brutal on the working class.
Right. The argument of the progressive reformers was that industrial capitalism created new, massive risks, horrific workplace injuries, mass urban disease, unemployment that individuals simply could not manage alone.
So the American Association for Labor Legislation, the AAL, actually drafts model legislation for compulsory health insurance at the state level.
They did, and it failed spectacularly. But why it failed established a political template that we will see repeated over and over again in American history.
Who was against it?
Well, the AMA opposed it fiercely, claiming it would restrict physician autonomy and income. Emerging private insurance companies, particularly those selling life and burial insurance, opposed it because they feared a state takeover of their business. Employers opposed it because of the proposed payroll taxes.
But the research highlights one opponent that genuinely surprised me: organized labor. Samuel Gompers, the powerful head of the American Federation of Labor, actively campaigned against compulsory government health insurance. Why would a labor leader fight against health care for workers?
It seems completely counterintuitive today, I know, but you have to understand Gompers' philosophy. He had a deep ideological suspicion of state paternalism. He firmly believed that if the government started providing a baseline of social benefits, workers would have less incentive to join unions.
Oh, I see.
Yeah, he wanted unions to win those better benefits for workers directly through collective bargaining. He viewed government intervention as a threat to union leverage.
Wow. So you have a coalition of doctors, businesses, insurers, and labor unions all shooting this down, and then World War I breaks out.
Right. The entry of the U.S. into World War I in 1917 was the final nail in the coffin. Suddenly, anything associated with Germany, including the Bismarckian social insurance model, became politically toxic. Opponents brilliantly rebranded the AAL's proposal as a Prussian menace and un-American. The first major attempt to build a national system died right there.
Fast forward a couple of decades to the Great Depression and the New Deal in 1935. Franklin Delano Roosevelt is designing the modern American welfare state. He's building Social Security. Health insurance was heavily discussed by his Committee on Economic Security, right? Why wasn't it included?
The political calculus was purely pragmatic. FDR deliberately dropped health insurance from the final package. His advisors read the political winds and warned him that if he included health insurance, the AMA would mobilize its immense resources and successfully kill the entire Social Security Act.
So they essentially sacrificed health care to save old age pensions and unemployment insurance.
Exactly. They thought they could come back for health care later once the foundation of Social Security was poured. But the later never came for FDR. He was consumed by the Depression and then World War II. It fell to his successor, Harry Truman, in 1945.
And Truman proposed a national health insurance program, didn't he?
He did. And if you look at the text, his proposal was actually quite moderate.
Right. He wasn't trying to nationalize the hospitals or put doctors on the government payroll like they were preparing to do in the UK with the National Health Service.
Exactly. Truman just wanted a single federal program to finance health care, funded through payroll taxes. The doctors would remain in private practice, and the hospitals would remain private. He essentially wanted to socialize the financing of care to pool the risk across the whole population while keeping the delivery of care private.
But the response from the medical establishment was just historically ferocious. The source material details this massive PR campaign in 1949. The AMA hired a California-based public relations firm called Whitaker and Baxter, and they unleashed a massive war chest.
They spent $1.5 million, which was an astronomical sum at the time, on a single, sustained, highly coordinated messaging campaign. They sent millions of pamphlets to doctors' waiting rooms, and their core message was brilliantly simple and devastatingly effective. They called Truman's plan socialized medicine.
Socialized medicine, that specific phrase. The text notes how it became a permanent rhetorical kill switch in American politics.
It really was a stroke of dark PR genius. I mean, it was 1949, the Cold War was freezing over. By attaching Truman's moderate financing plan to images of Soviet totalitarianism and government overreach, Whitaker and Baxter completely paralyzed rational public debate.
It's just wild how they framed it.
Yeah. They framed any government role in healthcare financing not as a practical policy for managing risk, but as an existential threat to American freedom itself.
And it worked. Truman's bill stalled and died. And that phrase never went away. The text tracks its usage. We saw it weaponized against Medicare in the 60s, against the Clinton healthcare plan in the 90s, against the Affordable Care Act in the 2010s. It's like a political magic trick that just never loses its power to terrify.
Right.
But here is where the story takes a truly bizarre turn. While these massive, very intentional political battles were happening in Washington, there was an absolute accident happening in the private sector during World War II that permanently altered the trajectory of American healthcare.
This is perhaps the most consequential accident in American economic history. During World War II, the federal government imposed strict wage and price controls. The economy was totally overheated by wartime production, and they needed to prevent rampant inflation. So it became illegal for employers to raise wages.
Right.
But at the exact same time, millions of men were overseas fighting, and factories at home were desperate for labor.
So imagine you are a factory owner. You need to attract workers, but it is literally a federal crime to offer them more money. What do?
You find a loophole. In 1943, the War Labor Board ruled that employer contributions to fringe benefits like health insurance plans did not count as wages.
Oh, wow. So employers instantly start offering health insurance as a perk to get around the wartime wage controls.
Exactly. It was a massive workaround. Companies started buying group policies for their workers. And then the critical cementing of this accident happened in 1954. Congress codified this practice by updating the Internal Revenue Code to make those employer-paid health premiums completely tax-exempt for the employee.
I really want you, the listener, to just sit with this fact for a second. Think about the gravity of this. Your ability to get an MRI today, or afford insulin, or have a baby without going bankrupt is entirely dependent on an IRS bureaucratic compliance decision made in the 1940s to prevent wartime inflation. It is completely mind-boggling.
It is. And the long-term structural implications of tying healthcare to employment are profound and, frankly, devastating. First, it means that the exact moment you lose your job, which very often happens because you get sick and can't work, is the exact moment you lose your health insurance.
The umbrella is violently yanked away the second it starts raining.
That's exactly it. And second, as the text points out, it fundamentally changes how risk is pooled. Instead of pooling financial risk across the entire society, the young, the old, the healthy, the sick employer insurance pools risk only across a single company's employees.
Which structurally disadvantages small businesses, right?
Right.
Because they don't have enough employees to spread the risk, or older industries with aging workforces.
Right. But perhaps the most insidious consequence is the creation of a massive regressive tax subsidy. Because the tax exclusion on premiums is worth much more to people in higher tax brackets, the federal government is essentially subsidizing the health care of affluent, white-collar workers far more heavily than low-wage workers.
And politically, this accident created a fortress. Suddenly, you had a massive middle-class constituency that had relatively good tax-subsidized insurance through their employer. They now had a vested interest in protecting the status quo.
Yes, this middle-class bloc became highly suspicious of any push for universal coverage, not necessarily because they lacked empathy for the uninsured, but because they feared a new untested government system would disrupt their own comfortable arrangements.
So the political will for a universal system just evaporated because the most politically active segment of the population was already taken care of by their bosses.
Yeah.
Going back to our mansion analogy, we essentially just tacked on a massive, sprawling, highly inefficient employer-sponsored wing to the house entirely by accident. So the house is getting crowded and complicated. But millions of people, the elderly, the poor, the unemployed, are still left out in the cold. How did the government finally manage to build rooms for them?
That brings us to Lyndon B. Johnson's Great Society in 1965 and the creation of Medicare for the elderly and Medicaid for the poor. The source material analyzes this under the concept of the architecture of exclusion.
Medicare and Medicaid only passed because LBJ had massive post-1964 majorities following the assassination of JFK, and there was immense moral momentum from the civil rights movement. But the text focuses heavily on how they were constructed. It wasn't a clean process at all.
Not at all. To get these programs past the formidable opposition of the AMA and conservative critics, LBJ had to make massive concessions. For example, Medicare Part A originally only covered hospital care. Coverage for physician services Part B was added almost as an afterthought during intense legislative maneuvering to appease Republicans who wanted a voluntary alternative.
And Medicaid is even more fragmented. It was designed as a state-federal partnership. The federal government provides matching funds, but the states administer the program and set many of the eligibility rules.
And that specific design choice was a political necessity to secure the votes of Southern conservative Democrats. By giving states control over eligibility, it allowed those states to maintain highly restrictive coverage rules, effectively ensuring that generous benefits wouldn't disrupt the low-wage agricultural and domestic labor markets in the South.
But the most critical structural flaw, according to the research, is that Medicare and Medicaid didn't replace the private insurance system. They were just grafted right on top of it.
Precisely. And this is the genesis of the uniquely American multi-payer mess we live with today. You have Medicare for the old, Medicaid for the poor, private employer insurance for working adults, the VA for veterans, TRICARE for the military, and a huge pool of people left with nothing.
Every single one of these payers has its own distinct administrative requirements, its own unique billing codes, its own prior authorization processes, and its own proprietary drug formularies.
The administrative friction is just astronomical. The text provides a startling comparison. In the U.S., 25 to 35 cents of every single healthcare dollar goes purely to administration, billing, coding, claims processing, marketing.
Wow.
By contrast, single-payer systems like Canada or beverage models like the UK spend about 12 to 15 cents on administration.
So we are pouring hundreds of billions of dollars a year into a bureaucratic black hole just to manage the complexity we created. It feels insane. Why build it this way?
Because of the political constraints of 1965. If LBJ had pushed for a streamlined, single universal system that eliminated private insurance entirely, the combined lobbying power of the AMA, the private insurance industry, and conservative state legislatures would have tanked the whole thing. The multi-payer chaos was the necessary compromise for survival.
Okay, so the text paints a pretty bleak picture of how we got here. But one thing I really appreciate about the source material is that it doesn't just attack the system blindly. It takes a moment to steelman the status quo. It lays out the strongest possible empirical arguments for why the U.S. system functions the way it does and why some defenders argue it's actually superior in specific ways.
Yes, this is crucial for an impartial analysis. We have to engage with the defenses of the American model. The defenders typically point to four main arguments: innovation, rationing mechanisms, choice, and transition pragmatism. Let's explore innovation first.
Here's where it gets really interesting. The argument is that the U.S. basically subsidizes the rest of the world's medical advancements. Through the National Institutes of Health, which pumps about $47 billion into basic scientific research annually, and critically, through the uniquely high prices Americans pay for drugs and devices, we fund a disproportionate share of global research and development.
The claim from pharmaceutical companies is that other countries like France or Japan can negotiate rock-bottom prices precisely because the American consumer is paying the massive premium that justifies the astronomical fixed costs and high failure rates of drug discovery. If America implemented European price controls, they argue, the pipeline of life-saving innovation would dry up globally.
But the research text pushes back on this, noting it is a heavily contested empirical claim among health economists, because how much of that high list price actually goes into lab research versus marketing budgets, executive compensation, stock buybacks, and shareholder returns? It's heavily debated. The NIH funds a massive amount of the basic science, and then private pharma swoops in, patents it, and charges Americans a premium. It's a serious argument, but it's not a closed case.
Fair point. Let's move to the second defense, rationing. This is a hard truth of health economics. Every single system in the world rations care. You cannot provide infinite health care to infinite people.
Sure.
Beverage-style systems like the NHS in the UK or single-payer systems like Canada generally ration through time. You might wait 6 months for elective knee replacement or wait weeks for a non-emergency MRI. The U.S. system, conversely, rations through price and insurance status.
Which means if you have excellent platinum insurance and money in the bank, you get same-week specialist appointments and incredibly fast surgeries.
Exactly. For an individual patient with significant resources, the sheer speed and responsiveness of the American system is a massive advantage. You don't wait.
But I have to challenge this based on the data in the text. Is that speed actually a systemic advantage, or is it just a VIP fast pass for the wealthy and the well-insured? While that executive gets his MRI in 2 days, there are millions of uninsured or underinsured Americans who are effectively blocked from getting in the line at all.
That's a very valid perspective.
Right. If rationing by price means a single mother goes bankrupt or delays care until a tumor is inoperable because she can't afford deductible entry fee, that speed isn't a feature of a highly functioning system. It's a luxury good operating inside a failing system.
That is precisely the moral and economic tension the text highlights. The system works spectacularly well for those who can afford it and brutally for those who cannot. The third argument defenders use is choice and competition.
Right. They argue that having a plurality of private insurers and independent providers avoids the pitfalls of centralized government-administered monopolies, which can become sluggish and bureaucratic.
They argue it creates competitive pressure that drives up quality. The U.S. has vastly more high-end diagnostic technology like MRIs and CT scanners per capita than most European nations. Furthermore, Americans are highly protective of their ability to seek second opinions or switch specialists without having to get permission from a government gatekeeper.
And the fourth argument is pure transition pragmatism. You have roughly 160 million Americans sitting on employer-sponsored coverage. And despite all the flaws, polling shows most of them generally like or at least tolerate their specific plans.
Unwinding a $4.3 trillion industry overnight would be an economic earthquake. It would mean historic tax restructuring, massive job losses in the private insurance sector, and immense disruption to hospital revenues. The political gravity of the status quo is immense.
But as the source material pivots to explain, we cannot just look at the costs of transition. We have to ruthlessly examine the actual costs of maintaining the status quo. The research makes a profound statement. It says, it's the prices, stupid.
And the macroeconomic numbers here are just breathtaking. The U.S. spends roughly $12,500 per person annually on healthcare. That consumes about 17% of our entire gross domestic product.
That's staggering.
It is. If you look at peer nations in Europe or Japan, they spend about 9 to 12% of their GDP, which translates to roughly $5,000 to $7,000 per person.
For decades, the standard American narrative to explain this gap was, well, Americans are sicker and we use more health care. We go to the doctor more, we get more blood tests, we stay in the hospital longer. But the text highlights a landmark 2003 study in the journal Health Affairs that investigated this exact assumption. And what they found completely dismantled that narrative.
The study was famously titled, "It's the Price is Stupid." The researchers proved unequivocally that Americans do not use more health care than people in other developed nations.
Wait, really? We don't.
No, we don't. We don't have more hospital admissions per capita. We actually see doctors less frequently than the Japanese or the Germans. We have fewer hospital beds per capita.
So if we aren't using more services, why is the total bill double?
What is different is simply what those exact same services cost per unit. An MRI in the U.S. is 3 to 5 times more expensive than the exact same scan in Germany. A normal vaginal birth costs 5 times more in the U.S. than it does in France. A hip replacement is 4 times higher than in Spain. A vial of insulin is 10 times higher.
So if it's the exact same procedure, using the exact same technology, why is the price tag so utterly massive?
It comes down to the total absence of central price negotiation. In countries like Germany, Japan, or France, the government or heavily regulated nonprofit sickness funds sits down with hospitals and drug companies and negotiates a standard universal fee schedule. Everyone knows what a broken arm costs.
Right, it's transparent.
Exactly. But in the U.S., every single private insurer negotiates separately with every single hospital system in secret. The prices are literally treated as proprietary trade secrets.
I really want you to picture this scenario to understand how absurd this is. Imagine you need to buy a car, but the dealership refuses to show you the sticker price. You aren't allowed to know what it costs. You are forced to test drive it, take it home, and a month later you get a bill in the mail.
Yeah.
And you find out the dealership charged you 5 times what the car is actually worth, simply because they know they're the only dealership in a 50-mile radius, and they know you needed a vehicle to survive. That is exactly how our hospital system functions.
That analogy captures the coercive dynamic perfectly, especially when we look at hospital consolidation. The text points out that in the early 90s, most hospitals were fierce independent entities competing with one another. But by 2022, over 70% of all hospitals had been absorbed into massive regional health systems.
And these massive systems effectively operate as local monopolies. How do they leverage that to jack up prices?
Through what economists call all-or-nothing contracting. A massive hospital system will go to an insurer like Blue Cross and say, if you want your customers to have access to our flagship, must-have cancer hospital, you also have to include all 50 of our suburban clinics in your network, and you have to accept our inflated prices across the board.
And if they say no?
If the insurer refuses, the hospital system threatens to go out of network, which would enrage the insurer's corporate clients.
So the insurer caves, accepts the higher prices, and just passes the cost onto the employers and employees in the form of higher premiums and deductibles. And the research shows these hospital mergers consistently lead to price hikes of 20 to 40% with zero measurable improvement in the quality of patient care.
Exactly. The consolidation is purely for market leverage, not efficiency. And if we think hospital prices are opaque, the text takes us into the pharmaceutical sector, which it describes as a system designed for profit.
The numbers here are truly sickening. Let's look at Humira, a widely used drug for autoimmune diseases like rheumatoid arthritis. In Germany, a year's supply costs about $16,000. In the US, that exact same drug, made by the exact same manufacturer, has a list price of around $73,000 a year. How is that legal?
It is legal because of how Congress structured the laws. The source material highlights a crucial piece of legislation, the Medicare Modernization Act of 2003, which created Medicare Part D to cover prescription drugs. In that law, Congress explicitly legally banned Medicare from negotiating drug prices with pharmaceutical companies.
Wait, the single largest purchaser of healthcare in the entire world, the U.S. federal government, was legally forbidden from using its massive volume to negotiate a bulk discount.
Yes, it was a purely political bargain engineered by the pharmaceutical lobby. The industry was basically handed a taxpayer-funded blank check. Furthermore, the text explains the bizarre role of pharmacy benefit managers, or PBMs.
I saw that in the research, but I need you to explain how that works. What exactly is a PBM, and how does it make drugs more expensive?
A PBM is a middleman. Originally, they were hired by insurance companies to manage drug benefits and negotiate discounts from pharma companies. Sounds good in theory, right?
Sure.
But the mechanism they use is called a rebate. The PBM tells the drug maker, we will only put your drug on our preferred formulary if you give us a massive rebate, a kickback after the sale.
Okay, so the drug maker wants to be on the formulary. What do?
To afford giving that massive rebate to the PBM, the drug maker artificially inflates the list price of the drug. So a drug that should cost $100 gets its list price jacked up to $300. The PBM negotiates it down to $150, claims they save the insurer money, and pockets a cut of the rebate.
But the uninsured patient or the patient with a high deductible who hasn't met their limit yet has to pay that artificially inflated $300 list price at the pharmacy counter.
Precisely. The system creates a perverse incentive where middlemen profit from higher list prices while the most vulnerable patients get crushed by them.
And all of this, the opaque hospital monopolies, the legislative bans on negotiation, the predatory PBM rebates leads directly to the human toll. This brings us to what the text calls the uniquely American catastrophe, medical bankruptcy.
This is where the macroeconomics of high prices crash violently into fragile human lives. The most prominent landmark studies on this phenomenon were conducted by researchers, including Dr. David Himmelstein and Elizabeth Warren, back when she was a Harvard bankruptcy law professor, long before she was a senator.
They dug into thousands of bankruptcy court filings to figure out why Americans were going broke. What did they find?
They found that medical issues, meaning direct medical bills and income loss due to illness, contribute to roughly 60 to 66% of all personal bankruptcies in the United States. We're talking about 500,000 to 1.7 million American families being financially wiped out every single year because of illness.
But here's the most shocking statistic in the entire deep dive, the one that completely shatters the fundamental myth of the American system. 75% of the people who went bankrupt due to medical bills had health insurance at the time they got sick.
It is a devastating data point.
Yeah.
It proves that having insurance in America does not equal financial safety.
Exactly. Your insurance is only as good as its loopholes. It doesn't matter if you have a card in your wallet, if your plan has a $10,000 deductible, or a 20% co-insurance rate for chemotherapy, or if the anesthesiologist who worked on you while you were unconscious during surgery happens to be out of network. The system bleeds people dry even when they did everything right, played by the rules, and bought the coverage.
And the catastrophe extends far beyond those who actually file for formal bankruptcy. The text notes that roughly 100 million Americans currently carry some form of medical debt. Over 12 million owe more than $10,000. And this creates what the researchers term a catastrophic cascade.
Because medical debt isn't just a bill on your kitchen counter, it is a slow-moving destruction of your entire life. It destroys your credit score, which means you can't rent an apartment, you can't get a mortgage, you can't get a car loan to get to work. It shatters families. The data shows intense financial stress is a leading predictor of divorce.
And tragically, most tragically of all, medical debt physically kills people.
How? Explain the mechanism of that.
When patients accumulate mounting medical debt, they become terrified of interacting with the healthcare system. So they actively avoid critical follow-up care. They cut their pills in half. They skip diagnostic testing like a follow-up scan for a suspicious lump out of sheer terror of receiving another bill they can't pay. So a highly manageable condition is allowed to quietly progress into a fatal stage 4 crisis. The financial toxicity of the system actively, structurally discourages people from being healed.
If you are listening to this, you have to ask the obvious question. If this system is so obviously catastrophically broken for the patient, why on earth hasn't it been fixed? Why do we tolerate a system that kills its own citizens through financial terror? The source material gives us the brutal mathematical answer: the wealth extraction machine.
What's fascinating and horrifying here is the realization that the system isn't actually broken. For the industries extracting wealth from it, the system is working flawlessly. It's performing exactly as designed. In 2022 alone, the healthcare lobby spent $693 million attempting to influence Congress. To break that down, pharma spent $373 million. Hospitals and nursing homes spent millions more. Insurers spent $170 million.
The ROI, the return on investment for that lobbying, is staggering. They are spending hundreds of millions of dollars to protect a $4.3 trillion annual revenue stream. It is the best investment they could possibly make.
And the text is meticulously impartial here in pointing out how this structural influence works across a political spectrum. This isn't a one-party issue. The architecture of congressional influence crosses the aisle seamlessly. Members of Congress who receive significant campaign contributions from pharmaceutical PACs consistently vote against aggressive price regulations, regardless of whether they have a D or an R next to their name.
The ideological framing, whether it's cries of socialized medicine on the right or highly complex technocratic policy justifications about market stability on the left, very often provides convenient political cover for straightforward financial interests.
Exactly. And the research highlights the bizarre, almost parasitic role of private health insurers in this wealth extraction model. We need to remember that private insurers do not provide health care. They don't heal anyone. They are fundamentally financial intermediaries.
Think about their actual value proposition from a business standpoint. For a private insurer to be profitable and please its Wall Street shareholders, it fundamentally has to collect more money in premiums than it pays out in medical care. Their entire business model mathematically requires them to deny, delay, or reduce legitimate medical claims.
They utilize an arsenal of bureaucratic friction to achieve this. Prior authorization hurdles force doctors to spend hours on the phone begging for permission to prescribe a drug they already know the patient needs. Narrow networks restrict where patients can go. And they use retrospective technical billing denials, denying a massive hospital claim because of a minor coding error, knowing that a certain percentage of patients and doctors will just give up and pay out of pocket rather than fight the appeal.
The tension is fundamentally built into the architecture. The patient's primary goal is to get care and get healthy. The insurer's primary structural goal is to avoid paying for that care.
But we can't lay the blame entirely on lobbying and corporate greed. The source material points out that political economy isn't the whole story. There's a deep cultural dimension. We have to acknowledge that Americans actually think differently about healthcare, about the state, and about each other than the rest of the developed world.
This connects deeply to American history. The text traces this back to classical liberalism, frontier individualism, and what is often called the American Creed.
Look at Europe. European nations went through the absolute devastation of 2 world wars fought on their own soil. Their economies were shattered, their populations decimated. In the aftermath, they recognized that collectivist welfare states, universal health care, strong social safety nets were functionally necessary for national survival and social cohesion.
But the U.S. never had that experience of total domestic devastation. We maintained a frontier mythology. We harbor a deep Jeffersonian suspicion of concentrated government power and mandatory taxation.
So what does this all mean for healthcare? It means we inherently view it through a different cultural lens. In Europe, healthcare is generally viewed as an inherent right of citizenship. You get it simply because you are a human being living in the society. In the U.S., heavily influenced by the Protestant work ethic, we tend to view healthcare as an earned benefit.
Because we accidentally tied it to employment during World War II, we internalized the idea over generations that you get good healthcare because you work hard at a good job.
That explains so much of our political dysfunction. It explains why Medicare, which is for the elderly who have theoretically paid into the system all their working lives, is politically untouchable. But Medicaid, which is for the poor and often unemployed, is constantly politically vulnerable and subject to funding cuts. It boils down to the cultural perception of the deserving versus the undeserving.
Precisely. When you view healthcare as a matter of rugged individual responsibility rather than social solidarity, the idea of a healthy 25-year-old being taxed to subsidize the care of a sick 60-year-old can feel, to some Americans, like theft rather than a necessary social safety net.
And in recent decades, this cultural divide has morphed into severe, toxic political polarization. The passage of the Affordable Care Act in 2010 supercharged this. The ACA made healthcare policy a permanent marker of partisan identity. Once a policy becomes tribal, your team versus my team, empirical arguments about costs, outcomes, and bankruptcy become practically useless. People vote based on tribal affiliation, not health economics.
And it's crucial to understand that this system of earned benefits, tribalism, and high prices doesn't impact everyone equally. The structural failures compound existing societal cracks. The research dives deeply into the fault lines of this architecture, specifically examining race, history, and rural crises.
The historical context is unavoidable here. The American medical system has a long, documented legacy of segregation and systemic exclusion. For instance, the Hill-Burton Act of 1946, which provided massive federal funding to construct hospitals across the country, explicitly permitted separate but equal facilities. Federal taxpayer money actively underwrote racially segregated hospitals until the 1960s.
And the integration of those hospitals didn't happen out of the goodness of anyone's heart. It happened because the federal government used the rollout of Medicare in 1965 as leverage. They told hospitals, if you want this massive new stream of Medicare revenue, you have to desegregate your wards.
But the legacy of that two-tiered system remains deeply embedded in health outcomes today. The contemporary disparities are chilling. Black maternal mortality in the U.S. is roughly 3 times higher than white maternal mortality, even when controlling for income and education. Black infant mortality is twice as high.
The text mentions a physiological concept here called weathering. What is that?
Weathering is a public health concept describing the accelerated physiological aging and health deterioration caused by the chronic everyday stress of systemic racism and marginalization. The constant fight-or-flight stress response literally wears down the body's cardiovascular and immune systems, making marginalized populations vastly more vulnerable to disease, which the fragmented healthcare system then fails to adequately treat.
And these racial disparities intersect directly with geography and politics. Which brings us to the rural crisis. The data here is terrifying for anyone living outside a major city. Since 2010, over 180 rural hospitals have permanently closed their doors.
And a massive, disproportionate number of these closures are concentrated in southern and midwestern states that made the political choice not to expand Medicaid under the Affordable Care Act.
Let's connect the dots on that. Why does a state's refusal to expand Medicaid kill a rural hospital?
Well, rural hospitals operate on razor-thin margins. They treat older, poorer populations. When the ACA offered states federal money to expand Medicaid to all low-income adults, it was meant to give those rural hospitals a reliable stream of paying customers instead of treating the uninsured for free in the ER.
Right.
When state politicians rejected that expansion for partisan reasons, they deprived their own rural hospitals of the critical revenue they needed to survive. So the hospitals went bankrupt and closed.
And when a rural hospital closes, it is quite literally a matter of life and death for the community. If you have a heart attack or a stroke or severe trauma in medicine, time is tissue. Every minute matters. If the nearest emergency room is suddenly an hour away instead of 10 minutes away because your local hospital closed, you die in the ambulance.
It's that simple. And it's not just the physical hospital buildings. There is a severe worsening shortage of primary care doctors and specialists willing to practice in rural areas.
Then you layer the mental health crisis on top of this fragile infrastructure. The text goes back to the 60s and 70s when the U.S. pursued a policy of deinstitutionalization.
The original idea was well-intentioned. The massive state psychiatric hospitals were often warehouses of abuse. The goal was to close them down, invent new psychiatric drugs, and move patients into humane, community-based care centers.
But the follow-through was a catastrophic failure. The state hospitals were shut down, but those community mental health centers were never adequately funded by the government.
So we effectively pushed hundreds of thousands of severely mentally ill people out of hospitals and directly into prisons, jails, and homeless encampments. The penal system became the largest de facto mental health provider in the country. Furthermore, the private insurance system has historically treated mental health as secondary to physical health, utilizing massive parity gaps, meaning they severely limit coverage for therapy or psychiatric beds compared to surgical beds.
This systemic fragility, the rural hospital closures, the lack of mental health care, the economic despair, perfectly set the stage for the opioid epidemic.
An epidemic that killed over 80,000 Americans a year at its peak. And the source material is clear. This wasn't an accident. It was actively driven by pharmaceutical deceit regarding the addiction potential of drugs like OxyContin, coupled with massive regulatory failures by the FDA, and it absolutely devastated rural and post-industrial communities whose healthcare infrastructure was already hollowed out and unable to respond to a mass addiction crisis.
The takeaway from this section is profound. The system doesn't just fail individuals randomly, it fails systematically. It fractures along the historical fault lines of race, geography, class, and specific medical needs.
So knowing all this, the high prices, the bankruptcy, the inequality, it's time to look at the rest of the world's homework. The text dedicates significant space to breaking down how other developed nations successfully managed to cover all their citizens for half the cost.
The text highlights 3 main global models. Let's walk through them so you, the listener, understand the alternatives. First, the Beveridge model.
Named after the British social reformer William Beveridge. This is seen in the UK's National Health Service, or NHS. In this model, healthcare is provided and financed by the government through tax payments. There are no medical bills. The government literally owns the hospitals and employs the doctors. It is free at the point of service. And the UK spends about $4,200 per person annually.
Compare that to our 12,500. Next is the Bismarck model.
Used in countries like Germany, Japan, and Switzerland. This model uses private health insurance plans, usually financed jointly by employers and employees through payroll deduction. However, unlike the U.S., these insurance funds are heavily regulated, strictly nonprofit, and must cover everybody.
The prices.
The doctors and hospitals are private, but the government tightly regulates the prices. Germany spends about $7,000 per person. Japan spends around $4,500. And Japan achieves this while boasting one of the highest life expectancies and oldest populations in the world.
And finally, the single-payer model, often referred to as national health insurance.
The classic example is Canada. The providers are private doctors, run their own practices, but the payer is a single government-run insurance program that every citizen pays into. Because there is only one payer, they have massive leverage to negotiate low prices and keep administrative costs incredibly low. Canada spends about $6,000 per person.
The central lesson drawn from all three of these vastly different models is unequivocal. Universal coverage is cheaper, period. It's not a debate anywhere else in the world. Every other developed nation uses central price negotiation, universal risk pooling, and standardized administration. They fundamentally remove the unchecked profit motive from the basic function of health insurance.
And this is the part that is so vital for the listener to internalize. America's failure to adopt these mechanisms is not due to a lack of technical knowledge. We aren't confused about how to negotiate drug prices or streamline billing. We know exactly how it works. It is purely 100% a political choice to maintain the current extractive system.
Which brings us to the most significant American reform effort of our generation, the Affordable Care Act of 2010, and how that system subsequently handled the ultimate stress test of COVID-19.
The ACA, or Obamacare, was a massive legislative achievement. It expanded Medicaid to millions of low-income adults. It created online insurance exchanges with subsidies for people who didn't have employer coverage. And critically, most popularly, it made it illegal for insurers to deny coverage or charge more for pre-existing conditions.
But look at what it didn't do. The text emphasizes that the ACA left the foundational structural problems completely untouched.
It absolutely did. It didn't implement central price negotiation for hospitals or drugs. It didn't simplify the multi-payer chaos. In fact, it added another layer of complexity with the exchanges. It just layered new regulations and federal subsidies onto the existing fragmented, profit-driven architecture.
It was a massive compromise designed specifically to survive the lobbying gauntlet of the AMA, pharma, and the insurers. And then a decade later, the COVID-19 pandemic hit.
The pandemic exposed the fatal coordination failures of our fragmented system brilliantly and tragically. Because we tied healthcare to employment back in the 1940s, the mass unemployment caused by the economic lockdowns meant mass loss of health insurance exactly when a deadly respiratory virus was sweeping the globe.
The irony is so dark it hurts. To stop the system from entirely collapsing, the federal government had to step in with emergency measures. They temporarily expanded Medicaid coverage, made COVID testing and vaccines free, and massively expanded telehealth access.
They proved in real time that rapid universal government intervention could work when the political will was forced upon them. Medicaid enrollment surged to 90 million people. The uninsurance rate dropped to a historic low.
But once the public health emergency officially ended, the cruelty of the system snapped right back. The so-called unwinding process began, and states aggressively kicked millions of people right back off the Medicaid rolls, often for minor bureaucratic paperwork errors.
It all comes back to path dependency. Why is systemic reform so hard? Because we are trapped by the path we chose. 160 million people fear losing the employer insurance they currently have. The entire hospital sector, which employs millions of people, now relies on those artificially inflated commercial insurance rates to subsidize their operations and offset the lower rates paid by Medicare and Medicaid. Unwinding it threatens everyone's immediate stability, even if the long-term destination is vastly better.
But here is a twist in the research that completely broadened my understanding of the problem. The scope of health is actually much wider than just hospitals and doctors. The text dives into the concept of social determinants of health. And the financial ratio here blew my mind.
It is a critical insight. In the United States, we spend roughly $2 on direct medical care for every $1 we spend on social services. Things like housing assistance, food stamps, early childhood education. If you look at peer nations in Europe, they do the exact inverse. They spend $2 on social services for every $1 they spend on medical care.
Why does that matter?
Because poverty, housing instability, and food insecurity, which the U.S. has uniquely high rates of among developed nations, are the root causes of chronic illness. If you don't have stable housing, your asthma gets worse. If you live in a food desert and can't afford fresh produce, you develop type 2 diabetes.
So our macro strategy is totally backward. We intentionally starve the social safety net, which predictably makes millions of people chronically sick, and then we spend astronomical amounts of money in the emergency room trying to treat the advanced stages of diseases we could have prevented with basic social support.
Precisely. We medicalize social problems because it's politically easier to fund hospitals than it is to fund anti-poverty programs. And this dysfunction is severely compounded by the primary care deficit.
Let's talk about the doctors themselves. American medical students graduate with crushing debt, often $200,000 to $300,000.
And because of our skewed payment system, they are heavily incentivized to avoid primary care. The text explains the relative value unit, or RVU system.
I really need you to explain how RVUs work. The text mentions it, but the mechanics are a bit opaque.
Sure. An RVU is basically a point system used by Medicare and adopted by private insurers to determine how much to pay a doctor for a specific service. A secretive committee, largely dominated by specialist physicians, advises the government on how many points a procedure is worth.
Okay.
Historically, this committee assigns high point values to technical procedures, like inserting a stent or doing a colonoscopy, and very low point values to cognitive services, like a primary care doctor spending 45 minutes talking to a complex diabetic patient about diet and medication management.
So the system literally values a quick, invasive procedure vastly more than deep, preventative patient management.
Exactly. The result is a massive income gap. A procedural specialist like an orthopedic surgeon or a gastroenterologist might make $400,000 or $500,000 a year, while a primary care doctor or pediatrician might make $180,000.
So if you are a 28-year-old medical student staring at $300,000 in loans, the rational economic choice is to specialize.
And the macro result is a severe worsening shortage of primary care doctors. Without primary care, people can't get basic preventative screening. Their manageable conditions worsen in the shadows, and they eventually flood the vastly more expensive emergency rooms when the crisis hits.
The text uses one specific drug as the ultimate microcosm of all this dysfunction, and that's insulin.
It is the perfect tragic case study. Insulin was discovered in 1921 by researchers in Canada. They famously sold the patent to the university for $1 single. Their explicit stated goal was that this life-saving medicine should be cheap and accessible to everyone in the world who needed it.
Yet in the United States, the price of a vial of insulin jumped roughly tenfold over recent decades. Why?
Through a combination of oligopolistic parallel pricing by the three main manufacturers, who steadily raised list prices in lockstep, and the exact PBM rebate demands we discussed earlier. The higher the list price went, the more the PBMs profited, while uninsured diabetics were left paying hundreds of dollars a month for a century-old drug.
We literally had caravans of Americans organizing bus trips to drive across the border to Canada to buy a drug invented in Canada just so they wouldn't slip into a diabetic coma and die. It is a profound national embarrassment.
Now, the Inflation Reduction Act of 2022 did finally cap insulin out-of-pocket costs at $35 a month. But crucially, that cap only applied to Medicare patients initially. It literally required a bruising act of Congress to fix the price of one single drug for one specific subset of patients. It wasn't a systemic fix. It was a highly targeted political Band-Aid.
Which perfectly frames our final analysis. Where does this leave us regarding reform? The final section of the text outlines the promise and limits of our current political options.
The debate generally falls into three camps. First, Medicare for all, or single-payer.
The pros are obvious. It would solve medical bankruptcy overnight. It would eliminate the hundreds of billions in administrative waste generated by private insurers. Every American would have the same card.
But politically and economically, the opposition is currently insurmountable. The transition costs would require a massive restructuring of federal taxes. You would essentially be abolishing the private health insurance industry, which employs hundreds of thousands of people. And the 160 million Americans with employer plans are historically terrified of being forced into a new government system.
Okay, so if single payer is politically blocked, what about the public option?
The public option is a government-run insurance plan that would compete on the open market alongside private insurers. Anyone could buy into it. It is much more politically viable because it preserves choice.
But the critics of the public option argue it might become a dumping ground. If the public option accepts everyone, private insurers will figure out ways to push the sickest, most expensive patients onto the government plan while keeping the healthy, profitable patients for themselves. It could destabilize the entire risk pool over time.
Which leaves us with a third path, incremental reforms. Slowly expanding the government's power to negotiate drug prices, aggressively enforcing hospital price transparency, strengthening antitrust enforcement against hospital monopolies, capping out-of-pocket costs in the ACA exchanges.
But we have to ask the hard question. Is incrementalism just putting a tiny Band-Aid on a gaping, infected wound? Or is it genuinely the only realistic path forward in a politically deadlocked, hyperpolarized system?
The text notes a fascinating demographic shift that might change the political calculus entirely. It points to the pandemic generation millennials and Gen Z.
Right. Younger Americans who are heavily burdened by student debt, locked out of the housing market, and increasingly participating in the gig economy where stable employer-sponsored health insurance simply doesn't exist, heavily favor universal health care.
The old Whitaker and Baxter playbook, the fear-mongering about socialized medicine, just doesn't work on a generation that has no living memory of the Cold War and who are currently being financially crushed by the realities of the private market. They don't fear government health care. They fear receiving a $5,000 bill for an ER visit.
And the passage of the No Surprises Act in 2020 proved that when the public gets angry enough about a specific egregious abuse like out-of-network surprise billing, bipartisan legislative action is actually possible against the wishes of the medical lobbies.
We've covered an immense amount of ground today. We've traced the accidental wartime origins of employer-tied insurance, the massive intentional lobbying efforts that maintain our uniquely high prices, the racial and geographic fault lines, and the devastating, uniquely American reality of medical bankruptcy.
And that brings us to the profound, inescapable tragedy outlined in the text. The suffering caused by the U.S. healthcare system isn't an accident. It is the choice America keeps making over and over again.
Exactly. We know the solutions. Dozens of other developed countries have implemented them successfully for decades. We aren't lacking the intellect or the wealth. We just choose, structurally and politically, to prioritize the profits of the wealth extraction machine over the financial and physical safety of our citizens.
I want to leave you, the listener, with a final thought to ponder. The text details the financial mechanics brilliantly, but I want you to consider what this constant state of financial terror does to the soul of a democracy. When citizens intuitively feel that their own country's medical institutions view them not as vulnerable human beings to be healed, but as captive revenue streams to be extracted from, even at the cost of their total ruin, how does that erode the basic social trust required for a society to function at all? If the healthcare system treats you like prey when you are at your absolute most desperate and vulnerable, how can you ever be expected to trust any other civic institution?
That is the ultimate vulnerability. Health is the one thing none of us, no matter how wealthy or careful, can guarantee. A system that weaponizes that fundamental human vulnerability breaks the social contract at its deepest possible level.
And before we go, we want to mention that this entire incredible conversation is derived from the first book of the 30-volume series, To Preserve, Protect, and Defend the Soul of America. The book we explore today is titled Volume 1, America's Healthcare Crisis and Broken Public Institutions, authored by Sue B. Howell.
It is an absolutely essential read if you want to understand the forces shaping your own healthcare, and the book is now available in all Amazon bookstores across the world.
We enthusiastically encourage you to go check out the book, dive into the research yourself, and please leave comments and feedback. Thank you for joining us on this deep dive through the dark, complex mansion of American healthcare. Stay curious, stay informed, and take care of yourselves out there.
Goodbye, everyone.